right, welcome back. Yes, that's what we're focusing on this morning, just following up on that and see where we are at the moment. So we've got two gentlemen, as you've seen in that welcoming slide, joining us this morning to shed light on what is going on with that scheme and in the sector by extension. So Dr. Obi Emmanuel is the Commissioner for Health, Enugu State, and then we also have Dr. Tinko Ike, who is a surgeon with the National Hospital, also former executive of the Nigeria Medical Association. Gentlemen, good morning, and thank you for coming on today.
Good morning. Good morning.
Dr. Emmanuel, I did come across a certain article which said that only about, I think it's 20% of the 30,000 PHC facilities across the country were working, and that's raises some concern. Don't know if there's been an update to that. Perhaps you tell us. But listen to the governor, Ekiti State governor, talking about, no, primary healthcare official, talking about some of the factors and yardstick in consideration, the measures. Funding was key. So while telling us about how the states are taking this on, one wonders, but definitely you'll have some states who will not be as buoyant, or there are states not as buoyant as others. So naturally you expect them to inject a lot more funds for this program. So won't that be tantamount to having some sort of unfair advantage? Or tell us, how do the states even see all of this in the first instance?
Thank you for having me. You're saying how do the states see all this?
How are they taking it on?
The truth of it is that Nigerian Governors Forum is a forum of all the state governors. And being the leaders of the states and then having a forum and then coming together and making a declaration like this, it tells you that they have an agreement that they will make a commitment to improving on the evidence that is before us in the healthcare sector. Now, that is what happened yesterday. There is a reaffirmation of a commitment to make improvements. And you're talking about making those improvements in financing. Rome was not built in a day, like I would always say. So having an opportunity to come together and reaffirm and commit to making improvements is a step in the right direction.
Well, Dr. Tinko, you're a practitioner in that sector. So you've seen how it is in the sector. I mean, the primary healthcare system is crucial. It's like the fulcrum to ensure the secondary and tertiary sectors don't have a lot more influx if the PHCs were working as such. So from your experience, how have you seen the sector? How is it faring at the moment?
All right. Thank you for having me this morning. I think in the last 2-3 years, following the advent of the COVID-19 pandemic, there's been a ramp-up of function in the primary healthcare centers. In fact, you can see even from the indices available, immunization, which is one of the basic functions of the primary healthcare centers, has been ramped up from 33 to 57%. So that's a significant departure from what used to be. And from this initiative that the Nigerian Governors Forum is launching in conjunction with Bill and Melinda Gates, there's a hope that it will improve universal health coverage up to about 80%. You know, and you can see even recently the president, under the aegis of the Secretary General of the Federation, launched the Scales 3.0 strategy to see how they can ramp up immunization and also improve on primary healthcare delivery. And that initiative noted that Nigerians, at least about 27 or 29 million has been fully vaccinated for COVID-19, and at least 40 million Nigerians have had one shot of vaccine. And so the whole essence of this kind of initiative is to see that vaccination is improved, primary healthcare delivery is improved, and also you want to reduce, the negative indices that we have in our climb, vis-a-vis the under 5, mortality, nutritional challenges, early marriages, and all that. So the MICS, NICS survey is also like a tool to evaluate the progress of this program. And you can see from 2016, when it was launched till now, it's a significant improvement where you can, we now have up to 57%, the reduction in child marriage from 44 to 30% now. And also vaccination has also improved. It used to be 1 in 8 under 5 child dying annually. Now it's 1 in 10. So you can see that the statistics are significantly improved.
Dr. Manuel, could you give us a picture, perhaps in context of the primary health under one roof policy, of what is the situation at the moment in Enugu State?
Situation in Enugu State?
Yeah.
Okay. For Enugu State, from even the survey results, Enugu State has made a lot of improvement in a lot of the indices. And you find that, for example, immunization coverage, Enugu is one of the highest on immunization coverage in the survey. So what is happening in Enugu is that in Enugu, the health system of Enugu State has come together under an administration to ensure that we do all that is possible using teamwork to try to achieve the best in the healthcare indices. And a lot of what we're doing is trying to create a bridge between the technical knowledge that we have from the technical people that come together in the health sector and create a shared understanding between the technical people and the political class to be able to understand what needs to be done with the parameters that improve on primary healthcare under one roof, for example. Enugu is one of those places that already has one of the things that makes primary healthcare under one roof work. That is the State Primary Healthcare Board. So with this in place and working over the last few years, I am not surprised to see that the figures for Enugu State in the survey are looking good.
Do you set targets for yourself based on, say, past surveys? Do you say, this is what we got with child mortality, this is what we're getting with nutrition, and how do you work out policies to see how you can improve in future surveys?
There is a principle, and that principle is evidence-based decision-making. And that principle is being implemented. I come from a field of medicine that is public health medicine. It's not strictly clinical. It has a lot to do with management and the understanding of data and the use of data. And with the health system in place, we have, through the instrumentality of meetings, coming together to have workshops, working with stakeholders and partners, there is always that tendency to review. The principle is management. It's about planning, implementing, and then evaluating using the management cycle. And then we do that. For example, we institute things like annual operational planning. And we do a needs assessment before we even institute annual operational planning. So the needs assessment tells us where we are every year. And then based on where we are with our indices, we try to put in activities and tasks and align them to National Strategic Health Development Plan, where we also have our State Strategic Health Development Plan. So we align these things, and then as we're working on it, we try to track and see how we are making improvements.
Well, I do know that at the level of the Nigeria Governors Forum, I know that there's a place where the commissioners for health also meet to compare notes. One of the things that has stood out for the people who have conducted the survey are the disparities. How would you say that, states, when you come together, I do not know whether you attend the meeting of the commissioners for health, do you?
Yes, I do.
You are looking a bit at the...
No, yes, I do.
So when you compare notes with your colleagues from other states, other commissioners for health, what are some of the challenges that you have in common that you think might need maybe a more deliberate intervention at the federal level for you to be able to make headway?
More deliberate intervention at the federal level?
Yes.
We need to understand something, and that is that when we talk about health and we look at the Constitution, health is neither in the legislative or concurrent. So it's a joint effort that gives better healthcare. Now, implementation of healthcare service delivery is at the state level, subnational. So a lot of support is coming, policy making, funding also from the federal to states. Mm-hmm. Now, what we're trying to do is to increase the synergy so that the policy and implementation can have a marriage that works. So when we meet and we discuss and compare notes, I have found personally that it's something that is really helping with healthcare delivery in the States, because the coming together and comparing notes is something that cannot go wrong, and it will help because, in a sense, people start to look at the positive things that others have done that have caused improvements in their own indices. And then we start to gain a lot of shared learning.
I'm asking that because, the disparity remains, and they're sometimes quite stark, and they're sometimes across, regions. In some instances, when you look at, say, a snapshot of a map like this, you might just see, in some areas, total blue, in some areas, orange, and it can be a bit troubling. So do you think, is it that the federal government might need to intervene in the areas of laws? Is it in the area of education? So that everybody can be uniform, so that we can begin to move towards some amount of uniformity?
There has to be the understanding that primary health care is the fulcrum of the best of healthcare in any community. Primary health care is defined as the front door to the health system, the front door to the health system that is made available to individuals, and it should be there all lifelong, and readily available. So, you see, at the states is where it should be happening.
Indeed. And I do know that, not just at the states, even at the local government level.
Yes.
A number of states have now taken on that responsibility. In fact, at some point, I think it was during the tenure of Professor Isaac Adewale that the federal government said that they were going to be intervening in the area of primary health care. And they intended to build, I think, one primary health care center in each local government or so. That didn't quite... I don't know how far they went on with that plan before that administration ended and another Minister of Health was put in place. But do you sense a sense of continuity in the federal government's intervention plans? Because I imagine that would have come up as a result of what the federal government might perceive to be slowness or, I don't know, maybe a lack of investment in that particular area in terms of what the states are doing.
Mark, I want to approach the question that you have asked from another direction, because I would like people to understand how health works. Now, health has undergone a lot of changes over time. Right back in 1948, the WHO would define health as a complete state of physical, social, and mental well-being, and not just the absence of disease. But fast forward a few years. Sometime in 1978, when it was realized that primary health care would be the best approach, making this health care available at front door, we had the Alma Ata Declaration. And then they gave a definition for health care, universally accessible, available, and all that. But the definitions have been changing. There was in 2018 another meeting, we were talking about the Astana Declaration, where something else, changed. But you see, the principles remain the same: social justice, community participation, equity, and the availability of this to everyone. Now, we have to understand also that with those changes, even that definition is being adjusted. Let me give you an example. Public health medicine is like the way the clinician will look at an individual and want to treat one individual. For public health, the public health will want to, and community medicine will want to treat communities. So you find that if health was a complete state, how many people do you really have that, how many places in the world would you even say that anyone has a complete state? If there were places that were described as developed world, developed countries and all that, and they had everything in place healthcare-wise and so on, just reverse back a little bit to COVID. COVID just broke that impression. And suddenly, the high-level places, it was like, look, we don't have it all worked out. So a few of us, you know, I come from the academia also, and then I'm serving as commissioner now. A few of us in health promotion and communication are beginning to look at the fact that health in itself is not a static thing. It's a progressive. And we're looking more at health like continuous adjustments to physical, social, and mental stimulus, and not just the absence of disease. Because as the stimulus comes, there are adjustments. Now, these adjustments are occurring all over the world. Nigeria is not exempt. We are adjusting. And what we do is that every once in a while, we get into that management cycle. We plan. We look at principles, policies. We implement them. Then we evaluate. And then after evaluating, we get back to the table and plan again. For example, in the Ministry of Health, if you know the number of meetings that we have for different programs and so on, all year round, you'd find that what we're continually doing is looking for ways to...
The point I was trying to bring out is that they're bringing out different results in different states. That's the point.
Okay.
These meetings are bringing out...
Let me ask you something. Just as individuals are different and will respond differently to several interventions, so you will have for communities. So it's not surprising that you will say that the results are different in different parts of the country.
Well, Dr. Tinko, how do the practitioners see this?
I think the best approach to it will be massive public enlightenment campaign. There are primary healthcare centers across the length and breadth of this country. But how many people know that when they have ailments that they can access care in the primary healthcare centers? And that is why you find these disparities, especially up north, where there is more of religious, social beliefs that health, so to speak, is how God has ordained it. So a child just dies of diarrhea, and nobody takes note of it. But if you are doing that aggressive public enlightenment campaign, I think there will be there will be a bridge in that gap. And this is the basis for this primary health care under one roof, where everybody... Okay, go ahead.
No, we'll pick up on some of what you lots have said, but our colleagues in Lagos have got questions for you as well. Go ahead, guys.
Thank you, Chamberlain. I think I'll just pick up from where you stopped with Dr. Ikea. So what Chamberlain asked you, Dr. Ikea, is how do the practitioners see this? And I'd like you to speak to the practitioners, the health caregivers themselves. How do they internalize some of these things, especially at the PHC level? You said that most people don't even know that they can access this basic care at the PHC level. The question is, why? What happened to perception, the perception of the primary health care centers as being capable and able to give them what they require without unnecessarily dying of these basics, just as you have said?
Yeah, like I said, how we see it is that if you don't know that there's a primary health care center in your place, then you will not also know that you need to approach care there. And you can see from the Nigerian Governors Forum launching yesterday, they didn't just do it. They called religious leaders, faith-based organizations to be part of it, the Federal Ministry of Health, and then the press was also amply represented. So this is all targeted at, disseminating information to the lowest level, so that Nigerians know that, okay, if I'm ill or my child is ill or my wife is pregnant, that care can be assessed. Like, as we're even having this discussion, this is a way of also
Let me rephrase that. Let me rephrase that.
Because...
Just 1 second, Dr. Ikea. Recently, the chairman of Nigerian Medical Association in Oyo State, Dr. Adeshina, I think, Dr. Fashola, said that thousands of doctors have become so disenchanted with the Nigerian healthcare system that they are actively migrating to more developed countries with better healthcare systems and economist. He went further to say, if we are not careful, in no distant future, Nigeria may have to import medical doctors into Nigeria. That's the angle of how do caregivers see this that I'm talking about.
Oh, okay. I think it's a work in progress. We all know the situation of our system. I don't want to be very specific now, but the economy is not good. Remuneration is poor. Doctors are finding greener pastures outside, and so and even nurses. And this is where it's impacting significantly on our health in the primary healthcare delivery system, because our nurses are living in droves. The doctors are also living in droves. And then government should also, in the bid to ramp up primary healthcare, also see how they can improve on incentives to keep our healthcare practitioners here in Nigeria, because it takes so much to train a healthcare practitioner, whether it's a nurse, a community health officer, or a doctor. So I think how we see it as healthcare practitioners is that the pocket is dry, and so wherever you can ramp up your pocket, you want to migrate down to that place. But these are things that deliberate policies of government can also mitigate, because that you are asking people to approach primary healthcare centers. How many doctors mount these primary healthcare centers? These are the issues, because even our tertiary hospitals, our secondary care delivery centers, general hospitals, we don't even have enough medical personnel there, let alone the primary healthcare center. So the earlier we begin to encourage our doctors, our nurses, our healthcare workers, to see that it's a national assignment to see how to improve the healthcare of Nigerians, the better. But beyond encouraging them, it's also encouraging them by way of incentives and improving on healthcare policies. Doctors are always on strike, nurses are always on strike. What is this thing that makes them go on strike every now and then? If we can fix these things, I think the perception will be different, and then you can see the results in the primary healthcare centers and also the tertiary healthcare facilities.
All right, let me ask Dr. Emmanuel, since he's serving Commissioner of Health in Enugu State, to be precise. Well, Dr. Emmanuel, I'm very happy that you mentioned the Amata Declaration of 1978, September 1978 to be precise. So consequent upon that, when Dr. Olukoya Ransom Kuti was appointed Health Minister in 1985, between 1986 and 1990, he facilitated a lot of work to the effect that he cascaded primary health care centers to all local governments in the country at the time, which didn't exist even at independence. Now, one of the strong points of getting that done was at the local government level, which Malcolm, my colleague beside you right there, also mentioned. The question for you then is, why do we have a challenge at the state levels, cascading authority to local government offices where the PHCs are supposed to be active? My colleague Chamberlain told you the other time that we were able to achieve a lot. You've spoken to the child immunization the other time. Back in 1990, we were able to achieve 80% of child immunization, and now we're aspiring to 80% again. So if we collapse the local government system, which is supposed to be the champion for it, how will we be able to do it at the state level alone?
Okay, thank you. I thank you for the history, taking us back in the history of primary healthcare and how it has been with Nigeria, with respect to Professor Olukoya Ransom Kuti. In truth, is that, like I've said, there is always this continual review and revision of policies and strategies. Like I said, after 1978, there has been a continual look at this and changes that have been occurring. And right now, what we're looking at is primary healthcare under one roof. We're looking at the integration of primary healthcare services under one management, which is the management of a state primary healthcare board. That's one of the principles that are in place. Now, the State Primary Healthcare Board is, the idea even of the primary healthcare is coming from the National Health Act, which stakeholders in health in Nigeria came together to push for and agree on. Now, what it is saying is that maybe the primary healthcare delivery being left alone for the local government may not be working as it should. So let's tweak it a little and see if we could now move it up to states and then have one management, have a board with a management team that trickles down into local government health authorities that will now institute healthcare at the PHC levels. Have discussions, keep monitoring and evaluating, and then making improvements, and then bringing up accountability lines from the local health authorities to state primary healthcare boards, to the ministries of health, and to the executive council governance. And also, when that doesn't really help, recourse to the national. I have said that it is a continuous review and process that is going on. When you implement the management cycle, for example, I've said it's plan, implement, evaluate, and then you re-strategize. There are so many policies that are there now that are helping. It's about us being able to put the correct things into practice, and we will continue to make that effort. We'll have to continue to make that effort. Forgive me, I'm eternally optimistic. I'm one of those. And I believe that if we keep working on it, we will start to get it right someday.
Dr. Emmanuel, I'm coming to you now, and for the same reason that I also asked this question, because you're a serving commissioner. I don't want us to lose sight of the fact that this report we're quoting, for which state governors are buoyed, and for which you are also beating your chest because Enugu State is quoted to have done very well, says that states primary health care, the condition across states of the Federation exposes the precarious state of health care in Nigeria. It shows that in all 36 states of the Federation, the facilities there are not particularly good. So there's a lot of room for improvement. And now the state governors have committed to funding. But just as Balkwe said earlier, in 2017, there was a commitment to the primary healthcare revitalization program. But 5 years down the line, only a certain percentage of primary healthcare centers in the country are functioning. Amid, the paucity of funds across, the country, especially at the federal level, how optimistic are you that state governors can indeed match words with action to commit to revitalizing primary healthcare centers across the country?
Forgive me if I have some sort of a tangential way of answering some of the questions you ask, but it's a short time, it's an opportunity. I want to state something clearly. For example, the improvements that we have gotten in healthcare delivery, they have not just happened in a snap of a finger. For example, if I will borrow from the clinicians, when somebody is an amputee, what we have in medicine is that we have had progressive improvements in prosthesis. That's the what the amputee will use. Initially, it was the immovable prosthesis that you would just cuddle along with. And then currently, you now have improved biomedical instruments that could even bend and mimic the normal state of walking. Now, put that also into the community and primary healthcare the delivery and public services and so on. It's about reviewing and improving, but not necessarily reinventing the wheel. Reviewing and improving. And that is what I see government doing. All these figures that we are quoting right now, we have been looking at them and seeing that even with the survey that has come up, there are some improvements. Things are improving. And the issue of the primary healthcare leadership challenge is governors, the people who have the ultimate approving power in the geographical areas that are the states that come together and make up the nation, coming out once more and saying that we recommit. For me, it's positive that we recommit. The governors are saying they are recommitting. It's positive. Let's adopt a positive outlook to this, and then everyone see what you can do. Because you see, with primary healthcare says, what can you do? Community participation. What can you also do? Sometimes this excessive pointing of fingers at government
Dr. Emmanuel,
sometimes does not always work right. What of you, the individual at Nigeria?
Dr. Emmanuel,
how much have you done?
I wish it were that simplistic, Dr. Emmanuel, given the current realities in terms of revenue, both at the federal and state levels. Don't also forget that it's only about a certain percentage of governors that are seeking re-election. Some have elapsed their tenure. So in terms of funding also and continuity of commitment to funding the primary healthcare program, let's be realistic about what's on ground and what is feasible. I'm told that we've run out of time for this bit of the segment. We'll take a break now, and then you'll respond to the question. Stay with Sunrise Daily. Welcome back to Sunrise Daily on Channels Television. We're looking at the primary health care system across the country, particularly with the report on the state of the primary health care centers across the country. And we still have with us Dr. Obi Emmanuel, who is the Commissioner for Health, Enugu State, and the surgeon, National Hospital Abuja, Dr. Atinko Ikea. Dr. Emmanuel, as we continue with our conversation on funding, which is critical to revitalizing the primary health care centers across the country, how optimistic are you with the current realities on ground?
I have said here that I'm eternally optimistic, and the truth of it about the issues of funding is that there is actually some evidence about the type of funding that will help to improve things. But, and some of the figures will talk about 15% of the budgetary allocation being given to health. But I also want to say that we are operating within certain realities right now. And the realities is economic depression. So you're talking about certain percentages. Let me just try to let our people to have a little understanding of what sometimes people in government have to go through. There is that big picture that is central group of people, and then one sitting governor always have to live with. And it is that big picture of prioritizing. There are several things on the table. There are issues of security, there are issues of need for greater education. There are pressing problems all over the place. Now, the job entails a continual prioritization, creation of a priority list, adjusting to, okay, what do we face now? Sometimes you get the impression that, look, you need to be safe, then you start to think about your health. So those are the issues that are available. With effective prioritization, we will gradually inch towards the targets that will give the appropriate results in the improvement of healthcare service delivery in the country.
Dr. Atinko, much as the primary healthcare under one roof policy was formulated in 2011, only became a national policy a few years ago. So at the moment, perhaps by way of measuring some of what the governors are doing, because he said they always look at the whole thing, reevaluate and try to improve, do better than what they've done before. So for you, as a practitioner who's out there, where at the moment do doctors gravitate towards? Primary healthcare for employment or tertiary? Where's the pull, the greater pull?
Sincerely, the pull is towards the tertiary. And the reason is simple, that the states, without any prejudice to my colleague here, as much as they have done so well in their primary healthcare delivery setup, the states are not doing well in terms of funding. Most of the primary healthcare interventions you see are basically from federal government interventions. The states see health as perhaps exclusive preserve, even though that is wrong, of the federal government in terms of funding. So you find very many states, not prioritizing primary healthcare delivery.
Till date?
Well, with the current realities on ground, there has been a shift, more like a paradigm shift, and that's why we are seeing these indices, improving. But before now, maybe before 2019, COVID-19 sort of geared us to some reality, reawakening to our realities. So the states have improved, but largely states are not doing well. In fact, doctors in the employ of state governments would give an arm and a leg, to be moved to a tertiary hospital. And that is not proper. Even in terms of remuneration, there's this inequality in terms of the CONMES salary structure. States are not paying optimally the way federal government pays. Even where federal government's payment is even suboptimal relative to other climes. Now imagine that states are now, performing at a suboptimal level. So these doctors, in fact, most of the doctors who are leaving this country are largely leaving from the states. Without also prejudice to state governments. Their state governments have not paid doctors for almost of 22 months. So how do you expect primary healthcare delivery to function in such a place where government hospitals are, not doing well?
Please, I need to correct an impression. The question was about doctors, where are they gravitating to? And please, let me correct an impression. Doctors don't, there are different levels of care. There's the primary, secondary, and tertiary. Now, doctors are not the major players in the primary healthcare. Doctors, they are major players in secondary and tertiary healthcare. So that's why, going back to Oliko Ransom Kuti and primary healthcare structure, at the primary healthcare level, you have other cadre, mostly the community health workers. Now, most of the primary healthcare centers will have the highest level as a community health officer in charge of a primary healthcare facility. Then you will have the community health extension workers, and then the junior community health extension workers, and even people they used to call village health workers who work in the communities and interact with people and bring information to the healthcare centers. And then what they cannot handle starts to go through referral up the ladder to secondary care and then to tertiary care. Now, secondary healthcare is going through its own throes, and there are a lot of challenges which a lot of people are working on to see how they can improve. Because, like I said before, primary healthcare is the front door that should be available close to you. But the community health workers should do their primary assessment of you and see what is there. What they cannot handle, they push on.
So could you shed a lot more light? So who are those that should approach the primary healthcare, and who are the practitioners, the professionals that man the place?
At primary healthcare level, you would have the doctors appear. Even at primary healthcare, you have different levels. You have the type 1 hospitals, type 2 hospitals, and the type 3 hospitals. You will usually find the doctors at the type 3. And it's also a referral thing. We have in primary healthcare what is called the hub and spoke model. And most of the states are trying to achieve that hub and spoke. For example, imagine a local government. You would imagine that you would want to have maybe like 2 type 3 primary health centers or 2 or 3 with doctors. Then you want to have around them type 2 hospitals, type 2 primary healthcare facilities headed by community health officers. And then you want to have type 1 hospitals headed by community health extension workers, bringing it closer to the doorstep of people. Now, when you have your problem and you come, community health extension worker works with something called a standing order. And that standing order is a simplified diagnostic matrix that allows them to identify what your problem could be and then make an intervention. Now, when that intervention does not succeed, the process is you refer to the next level. So they will refer to where you have the community health extension worker and then refer to the type 3 hospital where you have the doctor. And then when you cannot handle these things there, you're supposed to refer to the secondary care facilities.
You know, these
and
are all
disagree.
ideal.
Excuse
These
me.
are all ideal
well,
situations.
yes,
because
but we
we
need to
know
correct
that
the impression.
we know that in Nigeria,
Yes.
the way it works is that.
Sorry.
Just
sorry.
a moment. You know, we know that the way it works is that people rarely go to the hospital until they're really ill. We have the herbal practitioners, especially in rural communities, who look after people. I do not know whether there's been any effort to incorporate those people, you know, give them some formal training and incorporate them into the primary healthcare facilities. But usually people treat themselves first. If it doesn't work, maybe they're still seeking their local herbalist. If that is not working, and that's when they're now beginning to seek care. But you wanted to quickly say something.
Yeah, well, thank you, Honorable Commissioner. For an ideal situation, I mean, I don't see anybody losing anything putting a doctor in a primary healthcare center, because it will improve healthcare delivery, it will improve diagnosis, it will improve management. But you know, because of dearth of manpower, so to speak, and also lack of incentive, doctors are gravitating to the states and to the tertiary facilities, I mean secondary and tertiary facilities. But who says the doctor cannot man a primary healthcare center? But because of our peculiar situation, we have now made primary healthcare center like just places where they go and get immunization. No. I mean, you can treat malaria, you can treat diarrhea disease, you can treat, and then when you don't have the requisite skill, then you can push to the next level. So specialist care doctors are now in secondary and tertiary centers, whilst medical officers can also man these primary healthcare centers. But because we don't have the facility, or rather the manpower, or the financial muscle, or even the political will, so doctors have now been completely edged out of primary healthcare. But I would be rather more comfortable seen by a doctor in a primary healthcare facility than a community health officer. Not to say that community healthcare officers are not doing well, or community health workers are not doing well. But there's a limit to the knowledge they can exhibit. And that is why each time the National Primary Healthcare Development Agency is doing a program, they keep, you know, sounding it to them. Whatever you cannot refer.
Do you agree with him that there's nothing wrong with putting doctors in primary healthcare centers?
I don't agree completely, because I just tried to create and I tried to show you what the structure ideally should be. And that is what every effort is being made to put in place. I said doctors can man the type 3. Type 3 means a higher level of the primary healthcare center. So you have fewer of those ones. And then when you think about the wheel of a bicycle, you are looking at the central hub as a comprehensive healthcare center or type 3 primary healthcare center with a doctor and a nurse. They can perform surgeries there and so on. Then the spokes are like leading to lower level primary healthcare facilities because they've been trained.
I understand.
To do that. Then when
you said that's what is on that's what should obtain. We know that's not what obtains currently, and we know the challenges with that. A lot more interventions. I mean, even when we used to have a number of governors talk on health, a lot more of the interventions have tilted towards the type 3, which you've talked about, and the challenge has been being able to keep doctors at that level, even at the type 3 primary healthcare center. They found out that, especially for rural areas, many doctors do not want to stay. Are you seeing that as a challenge as well? And what do you think can be done to incentivize our doctors to stay, not just at the primary healthcare centers, but even at the tertiary level where we're beginning to have challenges?
With the kind of commitments that are being made now, if there's improved financing, and you have the primary healthcare under one roof structure in place, where the state primary healthcare boards are working as they should, you'll find that, you know, you'll be able to have that one management system, one policy and all that, that will be able to attract the correct funding that will pay the doctors that will be able to work at these type 3 facilities.
You agree with him?
Yes, I mean, if they can improve funding and then improve incentives, doctors are going to stay, because...
That's a big if. I just wonder, sorry, we need to wind down. Yes. So I'm just thinking, I wonder what kind of conversation the commissioners of health meeting, no pun intended, but for commissioners for Abia State, for instance, because when he was making the point as to how a law has not happened in that state, and yet they have this commitment going through. So you wonder. He said that some people just feel, well, yeah, we'll commit as much as we can. We'll do what we can. But, and by the way, the SGF did give us, I think that was some sort of verdict when he said they didn't know that the healthcare sector was that bad. And so we need to look deeper and see how we can strengthen not just the primary healthcare, secondary and tertiary, because he says it's a joint policy wherein both the state and government and the federal government can make laws to improve all of that. But gentlemen, we thank you all for coming on today. Dr. Obi Manuel, Commissioner for Health, Enugu State, and Dr. Ikaya Tinko, who is a surgeon at the National Hospital in Abuja. We hope that we'll have a lot more health professionals staying back in the country and providing that special expert professional care. We're back in a moment, and we will be talking some sort of politics. Stay with us.